sensations of the body, tactile sensations, position sensations, thermal sensations we ended up. And now we're going to talk about something that oftentimes an undergraduate, now all of you have had undergraduate physiology. How many of you really talked a lot about pain in your courses? And qualities of pain, where pain goes to the brain and how it's perceived. A resounding zero. And that's not unusual. That's not unusual. That's actually pretty common. I've never had more than 10% of the people raise their hand with that, and that's with people that have come from all sorts of different backgrounds. So we're going to talk about pain here, and when we usually think about certain things like pain's a perfect example of it, you tend to think of it as a bad thing, but it really wasn't a bad thing for our ancestors. Now we have ways of now having care. You're going to treat people in pain, and you can get them out of pain, and that'll be a good thing, because there's a number of horrible things that happen to a person when pain is unremitting, when it's continuing. It can just lead to this downward spiral of all sorts of bad things with other systems in the body. But actually, pain is considered a beneficial response. A beneficial response, at least in our ancestors, because it is the body's alarm system. It's pain, believe it or not, can be a good thing. And we all have freaky friends, and some go, oh yeah, I like pain. No, I don't mean like that, right? I'm talking about pain lets the body know something's wrong. So, if at all possible, get yourself out of that damaging, painful situation, because pain is usually associated with some type of tissue damage. If it's damage from some external source, like a saber-toothed cat biting your hiney and you're trying to screw it, well, that wouldn't work because it's fine. But anyway, if there's some external source, try to get away from it. If it's an internal source leading to pain, try to at least immobilize that area and try to let that internal damaged area have a period of recuperation. So pain is actually the body's alarm system, and I wasn't really the brightest bulb in the package, but when I worked for the Nebraska football team for years and years, and in the strength conditioning program, I computerized everything and worked with athletes from all sorts of different sports, and you wouldn't know it now, but that was like a whole lifetime ago. We had, I didn't mention about this kid, did I? Yeah, didn't think so. So there was a kid, he was a high school football player here in Lincoln, and through football camps and so forth, I actually got to know him when he had come in. He actually was able to work out as soon as he declared for coming to Nebraska. So I got to know him the summer before he was there. We all did. And so he played his freshman year, and this is sophomore, but it was actually the spring of his freshman year. So he's a nice kid, great kid. Everybody on the team liked him, worked really hard. And really a dark, dark day in my life. But it turned out to be an okay day. It was at practice, in spring practice, he suffered a neck injury. And boom, and I wasn't down on the field, but a number of the guys I worked with came up and they were just, ashen. They said, oh man, Randy got hit. He has a cervical, it looks like he has a cervical spinal issue, and it's really, really severe. So he was in the hospital, so we were just like, oh my gosh. We all thought he was going to die, and the physicians did too. And one of my friends was one of the trainers. He actually came down from, we talk about the Minnesota Vikings. He was their assistant trainer for the Minnesota Vikings, and he came down to be trained on strength and conditioning at that time. And so he happened to be on the field, and he'd come down for spring and summer practice. go back for the professional football season. And so I remember he came in that night and he said, man, I was in the emergency room and I'm holding his head and they're moving things, and I realized that I'm holding his head over space here, and if I let go, it turned out as a high cervical problem, so if you move, he stops breathing. And he was already in respiratory distress, so I just remember him saying, man, I'm sitting and going, oh Lord, I might pass out. Let's get somebody in here, And so we went from, oh, he's going to die, to he survived overnight. And then, oh, he's going to be paralyzed from the neck down. Wasn't. Oh, he's not going to be able to move one side of the body. He did. So a year later, he was back up and moving about in classes. And when he was tired, he would drag his left leg, and you'd see some deficit in his left arm. But normally when he's just walking around, I mean, everything on earth worked well for him. And of course, he was never going to play football again, but everybody loved the guy. So once he was able, he'd come in and lift weights with the guys. Of course, he'd lift a little bit differently than other people. But I was sitting in my office, crunching and putting together the workout sheets for the guys for the next week. And one of the assistant strength coaches comes running in. This would have been in summer. Following summer, crouch. Randy's he's just bleeding all over the place. And my response, did you put pressure on it? Good idea. And he's running back out, so I'm following, and there's a lot of blood. There's a lot of blood around. And Randy somehow had hooked the back. Now he would work with strength training machines rather than free weights at that point because of his issues. And somehow he caught the back of his leg on something and just tore it wide open. Now he had just been working his legs, so he had a lot of blood flow to his legs. So this was a venous laceration, a surface vein, which normally isn't a big deal. But here he tore this open, and he goes over and he's alternating legs up the body, and he's doing this, and he's not looking down, and somebody from the weight room over there goes, dude, what's going on over there? And he looks down, and there's this pool of blood. There's a stream of blood. And I was like, oh my gosh. It wasn't until that night I started thinking, here's a guy who could not sense pain in that area of his body, and that, even though it was venous, he was losing a lot of blood. And I never really thought until that night that pain can be a very beneficial, protective thing. I just hadn't really thought about it. And since that time, I've been fascinated with pain. Most people who think about pain end up being fascinated by it. There are a number of genetic mutations, and boy, I need, next time I'm going to bring in a slide to show you this. Maybe I could have slipped it in here. The voltage-gated sodium channels, turns out there's a whole bunch of voltage-gated sodium channels, but there are certain genetic mutations in that voltage-gated sodium channel that if a child is born with that mutation, they, in that pain transmitting pathway, that voltage-gated sodium channel doesn't work. Therefore, no depolarization phase, no action potentials, no pain. They're genetically insensitive to pain. Boy, oh boy, think about that. Those kids are fearless. Nothing hurts them. They see something on cartoons, they see an action hero do something, and they go out, get up on top of the shed, jump off, and they're going to do it. And they get hurt all the time. And they come walking, Mom, is my foot supposed to be turned around this way? Oh my gosh, And the kid doesn't bother them. They might feel a little pressure, but not pain. So raising kids that are genetically insensitive to pain, it's tough for the family because you're constantly having to watch the kids. And it's tough on the clinicians because, how do you help support this family? Because these are ongoing problems. Now, luckily, this is quite rare. But it kind of underlies that pain is a beneficial response, right place, right time. Unfortunately, it's not always right place, right time. Now, kind of as a little aside, you know, I've told you I've worked with a lot of different healthcare students, and I had a student a number of years ago come to me. So in a healthcare professional program that deals with pain. And she says, Dr. Crouch, I'm one of those people. One of those people what? You know, I didn't know what she was talking about. I'm genetically insensitive to pain. Oh, really? Tell me about it. And so we had a few different conversations, and she, before she went back to school, she had a child. Really sweet. Now, this is something that all the stars align, and you don't really pass. It's a genetic mutation, but they tend not to be passed on because of the recessive nature. Although there are some that are passed on. Anyway, so you know, I've seen her daughter before, a cute little kid. She says, well, you know, when I was in labor with my daughter, we were in this kind of birthing center, so there were all these labor rooms, and they kept the doors open during the labor period. So, you know, there were 4 other women in labor, and she was in the city. Well, I was in there, and, you know, I could hear them go, you know, really kind of working through it. And she said, my sister and I, we were playing cards. I was progressing through labor, and you know, the nurse comes in, oh my gosh, you're 10 centimeters dilated with 100% of face, you're having your kid. Oh, really? Well, we'll just finish this hand. Well, no, we're going to get in, we're going to deliver the kid. She said, oh, I felt pressure. I certainly didn't feel pain. And oh, you know, when labor was starting in the other rooms, they would close the doors. And she said, even with closed doors, I could hear women reacting the way women should during the birthing process. And she said, I didn't have any of that. And you know, I thought, well, that's pretty fascinating. And then over the years, just like this one made me start thinking, and I shouldn't even put this out, would you want to have a healthcare provider who's never felt pain? I think everybody should be able to pursue the job they want. But I mean, I started thinking, she's going to be in a tough situation. She's not going to be able to relate to things that you can relate to very readily. And pain happens to be a very individual thing, existing when and to the degree that the patient says it does. And there's so many different pain syndromes out there that if a patient says this hurt, and you go, well, that shouldn't hurt, say that in your mind, you shouldn't say it out loud. Guess what? The patient's right and you're wrong. Because pain pathways are highly individual and they can become sensitized. So there's nothing on here to memorize. I just want you, this is old, but I keep it here because this still all holds up. These are all of the accepted modalities, meaning paid for by insurance companies, for treating pain. So there's pharmacological methods, there's physical methods, there's psychological methods, and for any individual patient, you might have to do 1 from here, 2 from here, and 1 from there to find out what works. And whenever you see something like this, when there are a number of accepted ways of treating the problem, and it usually isn't just one, you have to do several things to treat the condition. In this case, we're talking about pain. It means whatever that condition is, it means it's complex. And pain is complex. It's not one size fits all, okay? But that doesn't mean that we can't talk about some general rules, and that's what we're going to talk about, general rules. Now, I've already talked to you about learning, and I showed you that, you know, if you get an idea and you're trying to recall it, you know, okay, there's an auditory part to that memory, there's a visual part to that memory, maybe there's a tactile or even olfactory part to that memory. And you know, the more you think about it, the more they come back. But if you continue to practice thinking about that experience, or thinking about that set of notes, or thinking about what you saw happen at the mall 2 weeks ago, if you continually thinking about that, you keep practicing recalling that memory, and you know, when you're doing it with your notes, it's called studying, you know that you can recall that information more quickly, more completely, and more accurately. And I showed you how, because of that long-term potentiation, the more you turn on those pathways, you might have this many synaptic terminals and this many dendrites to begin with, but the more you use that line, the more synaptic terminals and dendrites. Do you remember we talked about that? And remember neural facilitation. Neural facilitation, the more often you use certain pathways, these postsynaptic neurons, the resting membrane potential can actually become closer and closer to threshold. That's what happens with learning. Guess what? That very same thing happens with pain transmission. The longer a pain transmitting pathway is turned on, the greater chance you have that long-term potentiation, that elaboration of the synaptic machinery. The longer that pain pathway is turned on, the more likely you're going to have neural facilitation. So, if a person's been in pain for a long time, it can take less and less. Now this is far more peripheral pain than central pain. Pain arising from the periphery and then being transmitted to the central nervous system. Some central pains are just bad and they stay bad and they don't get worse, they're just plain bad. But this is really, it's more likely with peripheral pain as it's being transmitted to the central nervous system. The more that pathway is turned on, the more that pathway becomes sensitized, more easily activated, resulting in greater pain perception. And so starting about 15 years ago, there was a big push to more effectively treat pain. So there have been more and more pain centers that have popped up across the country. So within a pain center, there's a number of usually physicians and PAs with different specialties, you know, neurologists, anesthesiologists, people that are more in line with ortho type thinking. And then there's also behavioralists, there might be psychologists, there might be psychiatrists at that center, there might be a neurophysiologist at that center, so it's a group of practitioners that all their expertise together help that group manage patients' pain. Because if pain continues, you get poor quality sleep. What does that do? That causes depression. That causes immunosuppression. That changes heart function, driving up your blood pressure, put stress on the heart. It will make diabetes more poorly controlled. There's so many things bad things happen if pain is left untreated. So for a decade and a half, there's been this big push to treat pain now before it has a chance to sensitize pathways. Unfortunately, that has led to possibly the overprescription, at least the abuse of opioids that are used for treating pain. So there's a huge opioid crisis in this country, prescription opioid crisis, too many people misusing prescription medications, and now, because the federal government has issued crackdowns on how to prescribe those pain-relieving opioids, more and more people which activate opioid receptors, which you kind of got a little heads up on in that last exam. More and more people are turning to heroin. So heroin, which is a drug that really had fallen out of favor for a lot of the abusing population for a couple of decades, it's coming back because it's a cheap way. It's a cheap way of activating those opioid receptors. So, yeah, you need to treat pain, but you need to treat pain carefully so you don't lead to these unintended consequences, which certainly has happened in this country. So there's some things about pain that's just like learning. The more you study, the more quickly you can recall material, the more accurately, and the more detail you can remember. Well, the same type of thing happens with pain. You'll sensitize those pathways. So we'll talk very briefly about functions of pain, classification of pain, qualities of pain, how do patients describe pain. And we're going to talk about the biphasic pain response, something that most of you will have experienced at least once in your life, and therefore you can possibly relate to different qualities of pain. Neural pathways. Now, this is where I apologize. I'm going to show you because it's quick and easy, and it shows you just how close one area. I'm going to show you some things with teeth. Do I really care if you know things about teeth? No, I don't. But within a tooth, you're going to see that there's neurological wiring of one structure of the tooth for one type of pain, and 2 millimeters to the side of it, there's neurological innervation for a different quality of pain. And that's what you'll see throughout the body. Maybe not as close as what you'll see in teeth, but just by listening to somebody, if they say, this is stabbing pain, or, you know, and it's here, it's right here, and they're pointing to a place, and you go, here? No, here, I told you here. Oh, okay. Or they say, well, it's an aching thing. Last night it was here, now it's here. Lord, it's spreading, it's metastasizing, it's probably going to take over my whole body. You know, just by listening, stabbing, aching, localized, diffuse. Well, they won't say diffuse, they'll just say that's the area. You will have an idea what to look for and where. You're still going to do a full history and physical and check everything out, but your antenna is going to be going up for doing that differential diagnosis. Actions, local anesthetics, we already talked about that. Central sensitization, I want to mention a little bit about this. This is now, starting 15, 20 years ago, this is now a very important area. Referred pain. Sometimes pain is triggered from areas totally separate from where a patient perceives it. So, functions of pain. Yeah, pain is normally considered a beneficial protective response, especially during initial injury. During initial injury, it's alarm signaling, saying there's tissue damage. Try to get yourself out of that situation, or at least isolate that area that is damaged. And it's also beneficial during the healing phase. You know, when you have, most people have twisted an ankle or something like that. You suffer some type of trauma, and there is a transient, a short period when where there's this reversible peripheral sensitization. The pain response is exaggerated, and you don't want anybody to touch it, and you don't want to move it. And what does that do? That helps during the healing response. You are protecting that area for healing. So it's an alarm to tell you, try to get yourself out of that damaging situation. It also helps you during healing to try to localize and minimize further damage to that area, because it's sensitive. It hurts if you touch it, or it hurts if you move it. Now, pain becomes detrimental if it's chronic. And yeah, you learned all sensory receptors adapt except what ones? Pain receptors don't adapt. And what's the fancy word for pain receptor? Nociceptor, yeah. And pain is detrimental when it becomes dysregulated. That would include sensitizing the pathway. Okay, so now this didn't print out very well in your book. Pain can be classified by duration. And different healthcare professions will use, and also different specialties will use different cutoffs. Some groups say, well, acute pain is any pain that's lasting less than 2 months. Some will say it's any pain lasting less than 3 months. And some will say it's chronic pain if it's lasted 4 months or longer. Other groups will say it can be classified as chronic pain for 6 months or longer. So I'm not going to be able to ask any questions on that. I just want you to know acute, it recently came about. Chronic, it's been around a long time. Subacute, it's someplace in the middle. Okay? So you can hear about acute pain. You can also hear about the etiology. Is it pain due to a malignancy, or some type of cancer, or not cancer? So you might hear about acute non-malignant pain. It's also classified by the initiation. Is that pain the result of activation of nociceptors? Or is it due to the inappropriate activation of neurons in the central nervous system pathway? There is pain that we're going to see that will be generated even without pain receptors at that time being activated. Okay? So you might hear about acute non-malignant neuropathic pain, something like that. Now this didn't copy very well. So nociceptive pain means you feel the pain because pain receptors are being activated. If pain is being felt, and it's not because right at that time the nociceptors are being activated, that by default is called neuropathic pain. There is some dysfunction, there's some dysregulation in the nervous system, and the nervous system itself is inappropriately initiating the pain response. Now we can break down, oh, I guess I put this in here. So nociceptive pain is, let's say we activate these nociceptors and we have some type of activation. So it activates this peripheral neuron that then activates a central nervous system set of neurons. So we're activating a labeled line, which goes to the brain and you perceive pain. If you activate these nociceptors and you have pain, that's nociceptive pain. What if these nociceptors aren't activated, this peripheral neuron isn't activated, but something else is activating the central nervous system neuron? That's neuropathic pain. That's pain that's being activated by something other than pain receptors. That's neuropathic. There's something wrong. And it's incredibly common. Now, you can also talk about the qualities of pain, and there's different terminology, and you're going to hear about A delta nerve pain. You're going to hear about C nerve fiber pain. I use a terminology you might not hear a lot, so I want you to be flexible in your thinking. Some groups call A delta pain fast pain, and some call C fiber pain slow pain. If you remember, A delta fibers have conduction velocities of 10 meters per second. C fibers about how fast? 1 meter per second. Okay? So yeah, the pathways have different speeds. Now, as it turns out, here's the general rule. Your somatic body, out here in the periphery and the surface and in your joints, they tend to be, here's the general rule, there are exceptions, they tend to be innervated for the perception of A delta mediated fast pain. Whereas your viscera, your deep tissues and organs, the deep tissue of your organs, they tend to be innervated for the perception of slow pain. Now while you're on this, you might as well just jot down, this is often perceived as stabbing pain. This is often perceived as an ache. So different neural pathways give different pain qualities. Once again, these are the general rules, and once you've been out practicing for 3, 4, 5 years, you're going to go, boy, here's an exception, here's an exception. Yep, there are many exceptions, but the general rules, it's a place to start, and it works so often. So once again, if you just listen to your patient talk about the quality of pain, you have an idea right off the bat what to look for first. So let's talk about this biphasic pain responses. And I usually call this the I bet this has happened to you situation. Now, I need to get something across, and I know I put it in your notes. Not all pain responses are biphasic. Biphasic simply means there's two different pain responses and sensations to some type of an insult. Most pains in your body, it'll either be a fast A delta pain or a C, slow pain. They feel different, okay? But most of us have had a smash injury. You slammed your thumb into a drawer, or hit it with a hammer, or you've gotten up in the middle of the night and you're trying not to wake anybody up, and you stub your toe, you smash something. When you smash something, very commonly you get this biphasic pain response. You get 2 for 1. Isn't that sweet? But this is a way to help people go, oh yeah, I felt that. So let's say you smash something. So smash your thumb, other fingers, your toes, something like that, and just you know, I kind of call this the colorful language response. So very quickly, you have in your face pain. It's sharp, it's stabbing. Let's say you smashed your thumb. What do you immediately do? You know it's your thumb that's hurting. You grab and squeeze your thumb. Mom didn't have to teach you that. It's a reflex. And what are you trying to do when you're squeezing? You're trying to get a neural blockade. You're trying to compress neurons and get a neural blockade. And if you hit it just right, you can a little bit. But you're squeezing it because this is sharp stabbing in your face pain. It hurts. But after maybe a minute or so, it starts going away. So you go, ah. And then about 1 or 2 minutes later, you start going, ah. Whoops, I went a little too fast with that. And what often is it replaced by? This aching, da-thump, 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 this throbbing, aching pain, where now it's not just this one little area. It's a wider area that's just thump, 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 thump. So if you've done that, and you know that you have this initial sharp pain and then some type of aching, dull, throbbing pain later on, you've had a biphasic pain response. How many of you felt something like that? It's usually almost everybody. Now, this first wave, and you know that this time, they tend to overlap a lot. This time frame, you can't really put any label on it, but that first in your face sharp pain, that is being mediated by fast A delta pain transmission pathways. And that is felt as stabbing, sharp pain. But that ache or burning or throbbing sensation that you feel later on, that's being mediated by C nerve fiber or slow pain pathways. And most of us have felt those things. So you kind of have an appreciation what fast pain feels like and what slow pain feels like. Do you think most of you kind of know what the difference is now? So fast pain's rapid onset. Often you start feeling them within 1/10 of a second. Slow pain, it might take 1 second, 10 seconds. It might take close to a minute before that gets going. But the deal with it is it tends to build. And you start going, oh man, when is this going to start slowing down a little bit? So fast pain, it's intense, it's in your face. And the most common descriptor is stabbing pain, sometimes sharp electric pain, sometimes people call it lancinating pain. Whereas slow pain, it's very commonly an aching pain, a throbbing pain. It might be a burning pain. Some people describe it as a nauseous type pain. Compared to slow pain, fast pain is very well localized. It's not nearly as well localized as, say, somatic sensation, but compared to slow pain, it's much better localized. Somebody will kind of point to the area, whereas slow pains, they tend to be diffuse. It's an area that hurts. And you know, right off the bat, thinking back to what we talked about, somatic sensations, and where certain neurons have to project to have localized sensations and where they can terminate to have generalized sensations, maybe you might already are starting to think this through. Fast pain is usually not felt in deep tissues or viscera, whereas it's just the opposite of slow pain. It's usually deep tissues and viscera. Viscera means the internal part of the limbs. And slow pain is far more associated with tissue destruction and inflammation. And you can suffer with fast pain, but really unbearable suffering where people start becoming very depressed and start thinking very negative thoughts about how to relieve the pain, very scary thoughts. That's usually more associated with slow rather than fast pain. Okay, so fast pain, it's mediated by A delta pain transmission fiber pathways, and slow pain is C nerve fiber pain transmission pathways. So very possibly from now on, when you talk with your clinical professors, you're going to hear about A delta pains and C pains, or sharp pain pathways or ache pathways. You might not hear fast, slow. Different professions use slightly different terminology. So be a little bit mentally, intellectually flexible, and don't freak out. Oh, I haven't heard that term. Once they start describing it, you go, oh, I know which pathway you're talking about. Okay? So why do A delta and C nerve fiber mediated pains feel different? Because they terminate in different areas of the central nervous system. So here's the pain pathway for fast pain, and here's for slow pain. Let's kind of blow it up a little bit. So in both cases, it's something to do with close to the shoulder. Here's at the surface of the shoulder. This might be within the muscle of the shoulder. And look at the fast pain pathway. Now you've already learned about pain utilizes the anterolateral spinothalamic pathway, and fast pain goes up the neospinothalamic tract. Slow pain goes up the paleospinothalamic tract. You already know that. So here we have this A delta pathway. It's coming in via the dorsal nerve root. It's synapsing with its second order neuron, everything we talked about, crossing over to the contralateral side of the body, and it's going to go up the anterolateral spinothalamic pathway, but fast pains go up the neospinothalamic tract. Remember that? Feel that? It's going to activate, what's this red thing? Remember the reticular formation? Remember talking about that? That's your wakefulness and arousal center. If you poke yourself with a needle or something like that, does it suddenly alert you and wake you up a little bit? Yeah, it sure does. It sure does. You're suddenly more wide awake. And it'll terminate, the second order neuron will run to terminate the contralateral thalamus. And there are some third order neurons that go to where? Where in your cerebral cortex do you have good location discrimination? Somatosensory cortex, somatosensory cortex. So, fast A delta pains, you can localize them much better because there is at least some innervation of the somatosensory cortex. Whereas slow pain pathway, there's a lot of things similar. They're coming in via dorsal nerve roots, that first order neuron, right? And then you're going to travel up. Oh, wait a second. I didn't talk to you guys about neospinothalamic tract, have I? I'm sorry. Here's that slide coming up. Unfortunately, I'm going through this with 3 different groups simultaneously right now, residents and hygienists and you guys, and I forgot during general sensation the next 2 slides. I apologize. I meant to take a look. I show you guys this in a slightly different order. All you need to know at this point is, hey, these pathways look differently. They stop in different places. I'm sorry. But do look at it. Okay, this red thing, we did talk about the reticular formation. We did talk about that, I know that. But look at the, and we did talk about the anterolateral spinothalamic tract, and so itch, tickle, thermal sensation, crude tactile sensation, sexual sensation, and pain utilize the anterolateral spinothalamic pathway. But in this next slide, I'm going to show you that there's a fast lane for pain and a slow lane for pain. I'm sorry. That was bad. But do notice here, there's heavy bombardment of the reticular formation with this slow pain pathway, and it does not send third order neurons to the somatosensory cortex. And remember that somatosensory cortex gives you fine location ability, and it also gives you intensity gradation. Okay, now, I'm sorry. Now here's what the fast pain pathway might look like a little bit more specifically. Just what I showed you is projecting up here to the somatosensory cortex. And it is going up. Pain is conducted through the neo-spinal thalamic tract of the anterolateral spinal thalamic pathway. So that anterolateral spinal thalamic pathway, remember, think of it as a ascending superhighway. Itch goes up one lane. Tickle goes up one lane. Crude tactile sensation goes up one lane. Sexual sensation goes up a lane. And thermal sensation has its own lane. I might have already said that. But pain, it has two lanes, a fast lane and a slow lane. Neo-spinal thalamic tract, neo means new. So if you look at the phylogenetic classification of animals, and, we humans are on top, the organisms on top of that classification, we all have neo-spinal thalamic tracts. Where you go down to so-called lower animals, they just have a paleo-spinal thalamic tract. So we can sense sharp, pretty well localized pain that some other organisms apparently do not. They suffer pain, but it's perceived a little bit differently. So, primarily mechanically induced pains are transmitted through these A delta nerve fibers, so afferents from the body, surfaces, joints, some mineralized tissues. I'll show you with bone and yet teeth, absolutely. So we have the first order neuron coming in, the second order neuron ascending, and then there's a third order neuron going to the somatosensory cortex. Because it's going here to the somatosensory cortex, remember, that's that area that gives us some location discrimination. And also the ability to say, this hurts a little, this hurts more, intensity discrimination. We get that too. Now, substance P and glutamate are very commonly the neurotransmitters in pain transmission pathways. Substance P, that's easy to remember. Substance P and pain and glutamate are very commonly the neurotransmitters. Remember, each neuron can release one small, fast-acting neurotransmitter, but it can also release a number of different neuropeptides that can lead to neurofacilitation of this central nervous system pathway. So that substance P and glutamate are the ones that you tend to think about for neurotransmitters for pain pathways. So here's the slow pain pathway. It looks very much the same, but instead of going up the neo-spinal thalamic tract lane, the fast lane of the anterolateral spinal thalamic pathway, it's actually going up the paleo-spinal thalamic tract. Paleo means old. We humans and higher vertebrates, we have both neo and paleo-spinal thalamic tracts. You go down to lower, so-called lower organisms on the phylogenetic tree, they only have a paleo-spinal thalamic. This pathway, it terminates in the contralateral thalamus. So do you get sensation perception? Absolutely. But it feels qualitatively different. It's not sharp. It's more of a generalized ache.
Where did you say it terminates?
It terminates in the contralateral thalamus.
Oh, okay.
Yeah.
Thank
It terminates. So there's no third order neuron here going to the somatosensory cortex. And what else do you see? You see heavy innervation of the reticular formation. So, if you step on something very sharp, that's at the surface of the body. If you're just penetrating the surface of your skin, you're primarily activating A delta fast pain pathways. If you step on something sharp, are you suddenly kind of wide awake? What happened? Oh, don't do that again. But if you activate a slow pain pathway, unfortunately, this activates that arousal and wakefulness center. And it turns out your fall asleep neural center in your brainstem, which is also in reticular formation, and your wakefulness and arousal center, they're separate. They're separate nuclei. So, somebody who's suffering chronic slow pain, ask them, did you fall asleep last night? Yeah. About 100 times, meaning they fell asleep and woke up, fell asleep and woke up, fell asleep and woke up, because this is becoming activated. And one thing that is that's asked, and I'm not sure if you've talked about things with history and physicals yet, but I know from other medical groups, one thing that is asked when you're going through a history is, does this pain wake you up at night? And if it does, well, it's more commonly this type of pain, and therefore it's coming more commonly from certain locations in the body. Does that kind of make sense? Sorry, I thought those slides we had a different order. Okay, so substance P and glutamate, they once again are the neurotransmitter, really for all pain pathways. They're the most common ones. Whoops. Let me turn this off. Okay, so here are some pain transmitting pathways. There are, and I want you to understand this. We use A delta nerve fibers to do a lot of things in the body. We use A deltas for a lot of things. We use C's for a lot of things. But some A deltas nerve fibers are for pain transmission. Some C nerve fibers are for pain transmission. You saw A deltas and C's being used for thermal sensation. So not all, when you hear A delta, don't think, oh, that's just pain. It's not. When you hear C's, don't just think, oh, that's pain. It's not. But some are used for that. Now, here we have an A delta pain transmission neuron. These are peripheral nervous system neurons. Right over here are where we have our sensory receptors. You know some things about sensory receptors now. Now, A delta neurons, I mentioned to you that, oh, just remember about 10 meters per second. C nerve fibers, just remember about 1 meter per second. What's a good round number to think of for a alpha motor neuron? 100 meters per second. Okay. So that's from that table. So the pain receptors are found on these sensory nerve endings, and it turns out, you have what are called unimodal nociceptors on A delta pain transmitting neurons. And they're really only sensitive to one thing, and that's really mechanical perturbation. Mechanical perturbation, that's movement, vibration, pressure. Movement, vibration, pressure. Some type of noxious mechanical stimulation. So if you would stick, your skin is innervated for A delta pain. So if you'd stick a needle in the back of my skin, you know, that is a mechanical perturbation of those sensory receptors, and then that would be transmitted to my brain, and I perceive it as a sharp type of pain. Sharp type of pain. Now, on C nerve fibers that are used for pain transmission, they have what are called polymodal nociceptors. So they're sensitive to noxious mechanical perturbation. They're sensitive to noxious chemosensation. So these are mediators of tissue destruction and inflammation. For example, if you have tissue inflammation, you might have a lot of interleukin-1 or TNF-alpha or interleukin-6. Well, these chemoreceptors sense those mediators and activates that pathway. Tell me, you have what do you have inside of a cell? A lot of sodium or a lot of potassium? A lot of potassium. So let's say you have tissue damage and you have a cell break open. You now have flooded that local area with a lot of potassium. Guess what? These will sense elevated potassium and activate that neuron. So if you have tissue destruction or inflammation, those mediators and those ions, those will be sensed by these polymodal nociceptors. And also, if you have really noxious thermal sensation, that means really, really cold or really, really warm. We talked about you have cold thermoreceptors, you have warm thermoreceptors, and then you have pain thermoreceptors. This is what we're talking about here. If you're really, really cold or really, really warm, that'll also activate this neuron and transmit the pain sensation up toward the brain. So these are called polymodal nociceptors. These are called unimodal nociceptors. So seed nerve fibers they can sense a lot of different things and activate a painful message. Okay? Any questions on that? But both of them. So these are activated by, this is far more selective with what activates it, but these are going to activate neural pathways that will eventually terminate different areas of the brain, and you'll perceive the pain as differently. So, which is this, sharp or aching?
Sure.
Aching.
Yeah, that's right. That's right. So, nociceptors are considered high threshold receptors, meaning it usually takes quite a bit of stimulation for them to activate. They have a high threshold. But, and I've already mentioned, I think, nociceptors do not adapt. They do not adapt. Almost all other mechanoreceptors, odorant receptors, taste receptors, warmth, cold thermoreceptors, they do adapt. Nociceptors do not. That's both a good thing and a bad thing. It's a good thing in that it's telling you, you still have a problem, try to do something about it, get out of this situation or isolate that limb or whatever. It's a bad thing if you can't do anything about it. Yes?
So once a pain pathway is facilitated, can it be defacilitated?
Yes. Yeah, now these are peripheral nervous system neurons. The facilitation usually occurs in the central nervous. So let's say here's the spinal cord. So the facilitation normally occurs in the central nervous system neurons. So the question is, if they become facilitated, if they become sensitized, can you turn it back? Luckily, yes. It appears yes. And I'm going to tell you about some of the challenges of preventing it in the first place. But if you can turn off the pain initiation, if you can go to the source and relieve the pain at the source. Let's say it's an inflammatory pain. You have some inflammation going on. So if you give the person anti-inflammatory medications, so therefore this won't be activated because the inflammatory mediators will not be being produced. If this is turned off long enough, those central processes will return back to normal. That's part of neuroplasticity, thank goodness. So while these don't adapt, you know, you can have sensitization, but luckily they will go back to normal over time. Most of them will. Most of them will. So this is taken from this chart with the different type of nerve fibers. Yeah, I show you that A alphas are like 120 meters per second. A deltas are 10 meters per second. C fibers are 1 meter per second. You know, I have that chart that shows diameters and conduction velocities. You know what? Just go 1, 10, and 100. That's easy to remember. And guess what? They're in alpha. They're in kind of alphabetical order. A alpha, A delta, C. So oftentimes when I just think about nerve fibers, I default and I think about these nerve fibers that we use for activating skeletal muscle, that we use for the optic nerve, that we use for auditory nerve. But note, when we're talking about pain, we don't necessarily need that information in absolute real time. If we get the information within 1 or 2 or 3 seconds, that's good enough. And that's a good thing, because when you use smaller neurons, you can fit more of them into a small space. And therefore you can have more receptive fields. If you have large ones, you don't have as much discrimination sometimes. So yet there's some trade-offs with being a little bit slower, but they're smaller, you can get them into more spaces. And so boy, oh boy, the body's built right. If you were to engineer it and design it, that's what you do. That's what you do. Okay, so I'm now going to show you, just for examples of dental pain, pulpal pain. You don't need to know hardly anything about teeth in your life, but I just want to use these as a model of showing how in very small spaces, one area will give rise to fast pain, and in a very close adjacent area can give rise to slow pain. And teeth is a pretty good place to showing that. We're first going to talk about dental pain. It's a fast pain, so it's described as stabbing. It tends to be very well localized compared to slow pain perception. Why it projects the neuron to the somatosensory cortex. So it would be an example of a nociceptive somatic pain. Nociceptive somatic pain. I know that you know the copy very well. So here is, for the most of the people I teach now, not all, but most of the people I teach now, this is their view of the world. Oh, geez, very important. You got 32 of them. Brain, everybody should have one. So they think, oh, this is really important. So the blue area here, this is called your dentin. It's just below the enamel surface of your tooth. There's this dentin, and it's this tubular structure. There's just fluid-filled tubes, and there's a lot more tubes that run through this. And what I'm showing here is we have innervation of some of these tubules. This yellow thing is a nerve with many different nerve fibers. Here's a nerve fiber, here's a nerve fiber, here's a nerve fiber going up this nerve. So specific nerve fibers within that nerve. Different dental tubules are innervated by different nerve fibers, and it turns out this dentin is exquisitely sensitive. But you look at this pain pathway, it projects to the somatosensory cortex. So, would this be fairly well localized? Yeah. Would this be sharp or achy? Sharp, yeah. That would be. Just by seeing that, seeing that pathway, you would know that. You would know that. So let's say we have something activating the sensory nociceptor, and boom, it's firing, and we get action potentials being transmitted to the reticular formation and the contralateral thalamus, and also to the contralateral somatosensory cortex. So, knowing what you know now, this is a fast pain pathway. What type of nociceptors would be being used here? Would it be unimodal or polymodal? Unimodal, that's exactly right. So, noxious mechanical perturbation, movement, vibration, pressure. And it's actually just movement of fluid inside those tubes. And for example, how many of you have gone to the dentist and the dentist has either put a piece of dry ice or a very hot probe on the surface of your tooth? Any of you ever had that, a tooth vitality test? Just two of you here. Yeah, you put something with an extreme temperature on the surface of the tooth, and you think, wait a second, these unimodal nociceptors, they're not sensitive to temperature. That's true. That's true. But you put a piece of dry ice on somebody's vital living tooth, what does it do? It causes fluid pressure waves instantaneously in these fluid-filled tubules. So the temperature isn't transmitted. Pressure waves, just imagine waves going down through. And what do waves cause? Mechanical perturbation of these unimodal pain receptors. So your teeth, the surface of your teeth, they're not sensitive to temperatures per se, but boy, oh boy, can you get a pain response. And any of us with a living tooth, you put dry ice or something very, very hot, and that neuron is not sensing temperature, it's sensing fluid pressure waves, which activate those unimodal mechanoreceptors going in this first order neuron. And when we're talking about, up to this point, we've been talking about sensations coming into spinal nerves. But when you're talking about the neck and the front part of the face, you probably already know this from Gross, that information comes in at the level of the brainstem. It's actually coming in at the level of the pons, and it's synapsing in the medulla, in this trigeminal nerve tract. So sensations from the face, the facial area, the oral cavity, and a good part of the neck, that sensory information comes in at the level of the pons. It synapses with its second order neuron within the pons or medulla, it depends on which, and then just like we've seen before, it crosses over to the contralateral side of the body, and then that's basically going up what would be the remnants of the neo-spinal thalamic tract of the anterolateral spinal thalamic pathway to innervate that contralateral thalamus. Now, just right next to the dentin is this gray stuff, the pulp of your teeth. So dental pain mediated by A delta neurons gives rise to fast pain, very well localized compared to slow. Why? It's going to the somatosensory cortex. You told me it's unimotor pain receptors. I totally buy that. Let's compare that with pulpal pain. Just a millimeter or two away. A millimeter or two away makes a big difference because what different areas are innervated by different pathways. And you're going to, as you go through clinical medicine, you're going to hear, oh, something happening with the capsule of the liver, somebody will give this sensation. If it's something within, it may be a totally separate sensation. Same thing with the kidney, stomach, and so forth. So this is just an example. So here we have innervation of the gray area, the pulp, the anterior chamber. Look at this pathway. Yep, we have the first order neuron. Here we have an inner neuron. C fiber pathways often have inner neurons. You don't count them. So this is the first order neuron, second order neuron. You don't count them as far as being first order and second order neuron. Heavy innervation of the reticular formation. It's terminating in the contralateral thalamus. This is essentially what you would see for any organ in the body that is innervated for transmitting C fiber pain. If it's down in the body, it would actually be coming into the spinal cord, but if it's in the facial area, the oral area, the neck, it's coming in at the brain stem. But it's the same thing as far as a first order neuron, a second order neuron that crosses to the contralateral side of the body, heavy innervation of the reticular formation, innervation of the contralateral thalamus. And it's not projecting a third order neuron. So do you think you have good location discrimination here? No. It's an area that hurts. So somebody that has, for example, a hot pulp, you have some inflammation going on. Well, what's the first thing you notice with this illustration right now? It's slower. It's slower. This is going on C nerve fibers, so they're only going 1 meter a second instead of 10 meters a second. You're going to have heavy innervation in reticular formation. Is this going to wake you up at night? Sure will. Absolutely. And this is people who work with tooth pulled for a living, endodontists. One thing that they ask in their history and physicals is, does this wake you up at night? And it's also one of the questions asked in clinical medicine, does this wake you up at night? So pulpal pain is an example. Just like dental pain is an example of fast pain that's sharp, pulpal pain is a slow pain. Now, there might be one or two of you in here who's, not probably too many, but there might be one or two of you who's had a root canal. And you know, you probably had a ache, and it just really the side of your face ache. Well, that was a pulp problem. Some of you might have had a little surface carious lesion, not too many people anymore because of fluoride, but that is a sharp pain. And you know, you just kind of point it out, and they look, yep, there it is, we can restore that. So just like dentists, if they listen, okay, describe how does the pain feel and what's its distribution, and boy, I'll tell you what, when you have slow pain, it's kind of hard sometimes to find where it's being initiated because it's an area that hurts. So here it is with bone, and so I want you to just appreciate that as you go through your clinical medicine, you're going to hear differences about sharp pain and slow pain, but the surface of the bone, periosteum, is highly innervated with both A delta and C fibers. So golly, good luck with this. And yeah, I was ejected off. I had what was called still have it, don't use it, a Springer dog jogger apparatus that I got from Scandinavia. Hook it to the side of my bike, and my German short hair would pull me 10 miles, and I'm just like, wow, the pretty leaves, this is nice. Well, a young rabbit who hadn't learned the rules of the road, and I did have him on the left side. He runs across in front of us, and normally my dog's very steady, but he was going kind of slow. And my dog kind of dips toward the front of my bike, so of course, I jammed the brakes. Never jam the front wheel. I do a beautiful ending. I'm up in the air, over my dog, going, okay, he's stopping, that's good. And then I'm thinking, don't put my arm out, don't put my arm out, put the arm out, breaks the arm, you know. So I was lucky to experience, oh, I have both fast pain and slow pain. Well, that's what this guy has too. Both fast pain and slow pain. Now, the interior of bone tends to be innervated by C nerve fibers, tends to be. So when you have a surface fracture, you can have qualities of both ache and stabbing pain. That's not at all unusual. But there are some bone pathologies where you have different things occurring within the marrow chamber of the bone, and quite commonly those are achy. Not surprising, because that's primarily innervated by C transmission nerve fibers. So you're going to see a lot of these things clinically. The only thing I did with teeth is I just wanted you to see an example of, in very close proximity, within a millimeter or two, you can have innervation for sharp pain and you have innervation for aching pain. And you always listen to your patients, how they describe things. Local anesthetics, I think we probably all beat this thing to death. Lidocaine stabilizes the neuronal membrane by inhibiting ionic fluxes. What that is, it inhibits sodium going through the voltage-gated sodium channels, either for the initiation and conduction of impulses. The only way of saying that is inhibiting action potentials. So if you inhibit movement of sodium, if you close the voltage-gated sodium channel, you're going to inhibit action potentials and therefore affect anesthetic action. So, but staying with this, you know, so we go in, we inject. There is something I do want to point out here, that here we have this pulp, it has a problem, and the sensory receptors are still firing. Let's say we have an inflammatory problem here, and they're still firing. So this peripheral part of the neuron, it's still generating action potentials, isn't it? But what does local anesthetic do? It provides a blockade. These local voltage-gated sodium channels, they are blocked. So you don't have transmission centrally. So that's not just for teeth, that's throughout the body as well. And the other way of showing this is here's one of those voltage-gated sodium channels. And so out here's sodium, and here we have the current. It depolarizes, it springs the end gate open, sodium flows through. What does it do? It will recharge the membrane, might drive it up to a +40, and then that current goes on its merry way. So voltage gated sodium channels recharge the neural membrane. Remember, these membranes tend to be leaky if they're unmyelinated, so you need to have action potentials throughout the length of that neuron so you can keep this impulse going. What do local anesthetics do? You inject this local anesthetic, the red stuff, a little bit of it's going to diffuse across, and what is it going to do? It's going to block that voltage gated sodium channel. And therefore, here comes our current, and it's just going to die out because that membrane's not getting recharged. Kind of make sense? So you put in a chemical neural blockade right there with the local anesthetic action. And so I've already shown you this, that, yep, every place along the C fiber, local anesthetics working. Even if you inject someplace close by with myelinated, it eventually is going to diffuse. Remember, you just have voltage-gated sodium channels at the nodes for the nodes of Ranvier, or they simply call them the nodes for myelinated axons. So, yeah, C fibers tend to be anesthetized very, very quickly because there's voltage-gated sodium channels all along. But even if you inject in close proximity to the myelinated, it will, within a few minutes, diffuse over to a node, and you'll affect anesthetic action. Central sensitization, central sensitization. Okay, so central sensitization, it is an example of neuropathic pain. And neuropathic pain is an end result of pathological neuroplasticity. Now, we talked about that neural facilitation and long-term potentiation being examples of neuroplasticity. That just means the neurons change according to use. So that long-term potentiation, when you get more dendrites and synaptic terminals, when you have facilitation of the neuron, having its resting membrane closer to threshold, those are both examples of neuroplasticity, and I think I have a slide coming up on this too. Normally, this is how pain transmission pathways work. Here we have a peripheral neuron, there's some noxious stimulus here. It activates, releases little neurotransmitter. It might activate this. But if that pathway's been turned on a long time, over time, you have more with the elaboration of the synaptic machinery. And remember, this thing, this was really dark red. It usually had a resting membrane potential quite a ways away from threshold. But if this pathway's turned on long enough, you can have neural facilitation. So in this, yeah, you don't have colors on here. But I'm trying to show in both cases, long-term potentiation, that means more synaptic terminals, more dendrites, that's the physical structure. And you have neural facilitation. The resting membrane potential is closer to threshold. Bottom line, it's easier to send painful impulses up this pathway now. It's more easily triggered, it takes less input. And when it is activated, you get more of a perception of pain. So you get kind of this. Okay, so here's an example of nociceptive pain. You activate a nociceptor. You activate a nociceptor up here. It's going to activate the central nervous system neurons. Here is an example of neuropathic pain. Remember, the nociceptors aren't activated, but for whatever reason, the central nervous system neuron is activated. So this is non-nociceptive, therefore it's neuropathic pain. It's neuropathic pain. There's a dysfunction in the nervous system. So central sensitization is a driver of clinical pain. I'll get through a few of these. It was very slow to be appreciated. This guy, Wolf, described it in 1983, and boy, oh boy, back then, I remember I had instructors who said, well, this is just ridiculous. But his point was you can have remodeling of central nervous system neurons, and you can have the generation of pain without activating peripheral pain neurons. And, you know, if you live long enough, you can kind of say, told you so. So these notions of central sensitization, not very well received initially, particularly by physicians who believe that pain in the absence of pathology was simply due to individuals seeking work or insurance-related compensation, opioid drug seekers, and patients with psychiatric disturbances, malingerers, liars, hysterics. That a central amplification of pain might be a real neurobiological phenomenon, one that contributes to diverse clinical pain conditions, seem to them to be unlikely. And most clinicians prefer to use loose diagnostic terms like psychosomatic. The pain's in your head. And it's all of these. This is a short list now of all the different types of conditions. A very short list that has now been associated with sensitizing those central nervous system pathways with just what I showed you, with that abnormal neuroplasticity. So a lot of different things. If the pain persists long enough, those pathways can change. So, pain receptors are, like I mentioned, normally considered high threshold receptors. But you know what? I want to talk about hyperalgesia and allodynia. I really want you to understand those terms. So we're going to stop here because I do not want to rush through something and try to make. We will have any pictures on